Hi, Stacy. It's Cord. How are you?
Good. How are you? Welcome.
Doing good. Thank you.
You need to mute. Okay. Feedback.
You sound up. Yeah, I think.
Okay. Have we gotten rid of my feedback? Can everybody hear me? Okay. Okay. All right, good afternoon, everybody.
Good afternoon.
Good afternoon.
All right, we're gonna go ahead and get started. Welcome to the second Hospice Workgroup meeting. We're gonna focus today on quality. But first of all, we're gonna do some roll call. Jean Marie.
Welcome, everybody. Welcome, everybody. I'm going to just take a quick roll call. This roll call will just be for the people who are actually members of the work group, but everybody else, we do have you listed there, so don't worry, we know that you're here. So for the work group, we have Senator Pam Beidel, Delegate Tom Hutchinson, Delegate Ken Kerr.
I'm here.
Hello. Lisa Simpson.
Here.
Peggy. Hello. Peggy Shimoda. Okay. Monica Escalante.
I'm here.
Cord Kastner.
Hi, I'm here.
Hello. Catherine Hamill. I think she is not on this week. Rebecca Miller.
Here.
Hello, Rebecca. Lee Chambers from Medicaid.
Here.
Hi, Leah. Carlos Graveron.
I'm here. Thank you.
Hi. Carrie Craig.
I'm here.
Hello. Steve Faro.
I'm here.
Oksana Linkova.
I'm here.
Hello. Tammy Rossback. Okay. Tina Simmons. Brandon Rose.
I'm here.
Hello, Brandon. Amanda Wright.
Here.
Sarah McKay.
I'm here. Hi, everyone.
And then Dana and Heather, I know, are not going to be on the call this week. So that's,
Heather was there.
oh, she was there. Okay. I thought she wasn't going to be on. Okay, great.
And Heather's there too.
Dana and Heather.
Yes.
Oh, I thought they were both on vacation, but that's great. Okay. Okay, just a couple of quick Oh, in the room today with Stacy and I is Julie. Julie Beard is here and Ann is here. Reminders, all materials are posted on the website, including the slide deck for this meeting. Another reminder is to get your questions in for meeting number 4. This is the meeting where you guys are going to have the opportunity to talk with members of the community about hospice utilization. So please get those in. They can come into Stacy or I and also to Peggy at the Hospice Network. And then just a couple of house rules before I turn this back over to Stacy. No substantive comments in the chat just because it's difficult to monitor and present at the same time. Please introduce yourself before speaking and please mute your phones when you are not speaking. And I'm going to turn this back over to Stacy.
All right. So today we're going to focus on quality, as I said before. First, we'd like to review the current state health plan quality standard. And then we're going to review the current state and federal quality measures and also some upcoming changes to the federal quality measures. And then we'd like to spend the bulk of this meeting discussing ways to elevate quality standards for hospice care in Maryland.
Okay, so for the current state health plan quality standards, an applicant that is an existing Maryland licensed hospice shall document compliance with all federal and state quality of care standards. That same requirement is for also non-existing Maryland licensed general hospice providers. If you look at the third bullet point, an applicant that is not a current licensed hospice provider shall demonstrate how it will comply. Stacy and I have thought about including a little bit of language here that says that an applicant shall also demonstrate acumen in healthcare operations, just so that we get people who at least have some healthcare experience if they're not already a hospice provider. An applicant shall document the availability of quality assurance and improvement programs and demonstrate how it will comply with federal, state hospice quality measures.
Are there any comments about this change? Addition? Change? Okay. So when we talk about, so the current quality measures, to our knowledge, there is only one state level quality measure available for us to examine, and that's the Maryland Healthcare Commission Healthcare Worker Flu Vaccination Survey. This data is collected annually by hospices in October through March, and then it's reported to MHCC in April and May. And on this survey, we're able to report the percentage of employees and volunteers who are vaccinated against the flu. And we're also able to tell the number of employees and volunteers who are, the number of hospices that have 95% or more that are vaccinated. And we call those hospices Gold Star hospices. But on that survey, we collect a lot more than just vaccination. We also ask hospices if they have a mandatory policy. We also ask if there's an infection control coordinator, and if that infection control coordinator has attended basic infection and control training courses, and how many hours they spend in infection and control activities each week.
Hey, Stacy. This is Oksana from OHCQ.
Yeah.
So I'm not aware of OHCQ receiving inquiries about approving infection control training courses, and this is not something that we typically do unless it's written in our regulations. And I've checked our regs, and I didn't see. And I've been working with hospices for the last 3 years. I have not had a single inquiry from a licensed hospice about approving an infection control course. So is this something that has been around for a while and I'm not aware of it?
It's in one of our regulations. This is how it's written. Which one of the regulations is it? Do you think? There's one of our regulations that it's worded this way, the infection and control training course by OHCQ.
I don't remember the exact regulation.
It's written in one of our regulations this way, and this is probably one of the things that we need to update. So
Okay.
we're going to note that might need to be updated because that has been commented on before. But
Okay. Yeah.
so we have already made a note that we might need to update that. So
All right, feel free to reach out.
Okay. Are there any other comments on this one?
So what do you do if a hospice is not compliant? Do you put them on a cap? Like what do you do with that? This is Lee, I'm sorry.
If they were not to comply, we would institute a fine, but that has not been an issue. All hospices do comply. I call each one if they are late, and I work with them to get the data in. We haven't had an issue with that.
Okay.
And then at the federal level, we have the Hospice Quality Reporting Program. The majority of you on this call are probably already familiar with these quality measures, but some of you I know are not. So I want to make sure we're all starting off on the same foot. We have the Hospice Quality Reporting Program, which is mandated by the Affordable Care Act and managed by the Centers for Medicare and Medicaid Services. The intention of the Hospice Quality Reporting Program is to make sure that Medicare certified hospices are providing high quality care. And the data from the Hospice Quality Reporting Program is reported on the CMS Care Compare website, but we also report it on the Maryland Quality Reporting page, along with quite a bit of other additional state level data. So the key measures involved are the hospice care index, the hospice visits in the last day of life, the hospice item set, and the consumer assessment of healthcare providers and systems hospice survey, which is also known as CAHPS. So the hospice care index is a composite measure which is calculated from Medicare claims data. And the intention is to provide a broad overview of hospice care quality throughout the entire hospice stay. And it's made up of 10 individual indicators, and it's scored on a scale of 0 to 10. Here are all of the index items from the hospice care index. And if you take a look at these, you can see that it does span the entire hospice episode. And then next we have the hospice visits in the last days of life. This is a process measure, again, constructed from Medicare hospice claims records. This is assessed from in-person visits by a registered nurse or medical social worker during what's considered a critical period of the hospice care. And it measures the proportion of patients who are receiving at least 2 in-person visits from an RN or MSW on at least 2 of the last 3 days of a patient's life. So the intention for this measure is to encourage quality of care during what's considered a very critical period during hospice care. Okay, and then we have the hospice item set. This is another composite measure and a process measure. And this captures the proportion of patients where the hospice performed all 7 applicable care processes at admission. And the applicable care processes at admission are listed there on the screen. So we have the beliefs and values if desired by the patient, treatment, pain, dyspnea, and treatment with patients treated with an opioid are given a bowel treatment. I'm sorry, bowel regimen. Now, there's a big change coming. The hospice item set is only being collected through September 30th of this year. And then October 1st, the very next day, hospicers are going to be using the hospice outcomes and patient evaluation, which is called the HOPE. But the HOPE is not going to be publicly reported until late 2027. So we aren't going to be able to use any data from the HOPE right now. Anything that we do use, that we do decide to use, might have to include the HIS if we want to use that. Did I skip that? I skipped one, I'm sorry. Okay, well, I'll finish this. So the key difference between these two is that the HIS captures retrospective chart data, and the HOPE is intended to be a real-time patient assessment tool. So the goal of the hospice outcomes and patient evaluation is to improve care planning and quality measurement throughout the hospice episode. And I accidentally skipped this one. So the CAHPS, the Hospice Consumer Assessment of Healthcare Providers and Systems, this one's a patient experience survey. This one's specifically filled out by caregivers and caregivers and families after the patient passes away. And it's intended to capture the experiences with communication, care quality, and emotional support. So the family and caregivers fill out a survey, and then the items are calculated into 8 domains to assess how the family feels about the hospice. So are there any comments, general comments about the quality measures before we go on and start beginning to talk about them? Any general comments?
I just have one, and that is, Stacy, that's in regards to you all utilizing HIS after we actually stop utilizing HIS.
Mhm.
How do you foresee that happening if we're our EMRs are going to HOPE? Where's the HIS data going to be coming from still?
we're not proposing anything right now. That's
Right.
what this meeting is for, is to decide what we want to do with which measures at what time. It's to start feeling out what we want to do, what we all think is the best right now.
Right.
We're not saying we're going to or not going to do anything right now.
Okay, thank you.
Sorry, anything else before we? Okay. Okay, so staff has several suggestions. As we move forward with the state health plan, we are suggesting to change the language to keep it simple and broad. We want language to be descriptive, but not too specific, so that we can allow for some flexibility when it comes to quality. So for example, the home health chapter uses language that's very flexible, but it's not too specific. And here's an example of what we use in the home health chapter that allows us to be flexible. So the home health chapter says, since quality measures and the art of evaluating quality are evolving, this chapter describes the process by which consideration of quality will be used in qualifying applicants for scheduled review cycles. The chapter does not include the specific quality measures, performance thresholds, or improvement targets that will be used. Rather, these will be published for review and comment prior to the initiation of review cycles in which the application would be filed. So the language is allowing staff to, each application cycle, choose measures and measurement thresholds that allow staff to adapt to the needs of the industry, the needs of Maryland, the needs of the quality measures as they change, without completely rewriting regulations every time. So the big question today is, how do we ensure new and existing hospices provide high quality care? We have some more specific questions below that, but that's the big question. What are your initial thoughts and comments?
Just to kind of start the conversation a little bit, I often hear the verbiage, my hospice is a 3-star hospice, my hospice is a 5-star hospice. When you guys say that now, can you just explain, like, what does that mean when you say that? Just looking at the care compare, the stars only relate to the age caps. And so I'm just curious, are there other things that you're taking into account when you make those kind of statements? So I'll start it with that question.
Nobody's talking. This is kind of very, I would say that there's a star rating, and that is what we're talking about. It's not encompassing of anything other than that.
So it's just the families at it, the satisfaction survey.
Yes, I think Court Kasner is on the line. I'm going to put him on the spot. If Court,
Thanks, Heather.
thank you.
Uh-huh.
You're so eloquent when you speak about this. So,
Well, there's a few thoughts around the star ratings. The most prominent one that actually doesn't apply in Maryland is that only about 27% of hospices have a calculated star rating by CMS. Maryland has more because you have larger hospices because of the CON. In order for CMS to calculate a star rating, you have to have 75 completed CAP surveys, which means you have to have, you have about 20% response rate. So you're looking at 300-400 patients in order that have CAP surveys turned in to even get a star rating. So there's some question nationally around the utility of the star rating, just because more than 2/3 of hospices don't have one. But like I said, in Maryland, most of your hospices do have star ratings. People, in terms of my understanding, Heather, you or anyone else, certainly correct me. 3 stars or better, like that's, you want to contract with a hospice that's 3 stars or better. From a nursing home perspective, even a patient perspective, obviously you're looking for 5-star hospices if that's possible. Again, I don't want to get too far into the weeds with it, but one of the complications with the star ratings is we have also seen, I've spoken with folks at CMS about this, the larger the hospice, the lower the quality rating. So I've seen, in my opinion, really strong, healthy, good hospice providers that are 1 star. I've seen some lousy hospices that are 1 star, but I've seen really, I would put my mom in some of these hospices that are 1 star. So I think all of that to say, because so few hospices have star ratings, I think CMS is still kind of ironing out what that methodology should look like. They're using it, and I support using it. I support continuing to look at the methodology around it. But it's maybe a softer measure than I would like. I would like every hospice in the country to have a star rating. I like everybody to agree these are consistently applied and good indicators of quality. We're not there yet.
Court, I would agree. I think it's a hard question. It's a loaded question, especially with Maryland being a little bit different. I have a small organization in Pennsylvania, and because we are so small, we don't have a star rating yet. But when you look at, our HIS scores and you look at our CAP scores and things like that, you can tell that we're doing well as an organization, but we have no way of communicating that publicly unless outside of our marketing to people in the community to be able to show that, hey, against the other 9 competitors that we have in Franklin County, that, hey, we're actually outdoing the other hospices in that area.
So in terms of including it in a metric to be considered moving forward, I support that. I would have that as kind of a soft, maybe I think there are perhaps stronger quality metrics that could be used. Not to take this one off the list, but it would not be top of the list for me.
Mm-hmm.
Hi, this is Becky from Hospice of the Chesapeake. And I think to kind of take off from that, Court, I appreciate what you're saying. And for me, I agree. I think there's more to quality than the claims-based and the CAP scores. They do tell a part of the story, but if you're looking in Maryland to kind of tell the rest of the story, I think there are some other areas you can look at. One of our other requirements is doing face-to-face visits, for instance, and are those being done in person or via telehealth? We know that hospice is a high-touch business, and so we want to try to get people in front of the patients, and so we want to think about that. I know in our organization, we look at that as something we want to strive for. Even though telehealth is allowed, we like to do ours in person because it raises the quality and the meaningful experience for the patient and the family. I think also, in having done this work over so many years, it's so important when a family calls to be responsive and to get out there quickly. So we measure the length of time from referral to admission and making sure that that's a reasonable amount of time, that we're not taking too long to get out to see someone. So I think that's another indication that can certainly help from a patient and family perspective. I also would love to see us, and I don't have a good answer for this one, but I would love to see there's different quality metrics if somebody's on service a long time or if somebody's on service less than 7 days or 14 days or something like that. And so there might even be, I think down the road, nationally, we need to be looking at that too. And I know our national organization is looking at some of that, of how we can start to distinguish, because people that are on service a longer time sometimes don't need as much at the very end. But somebody who's only been on service a week, of course, needs a lot the whole week that they're on service. So those are when internally, when we at Hospice of the Chesapeake talk about quality, those are some of the things we're talking about.
Mhm. Yeah, I agree, Becky and Cord, and just kind of as a caveat, and maybe just to kind of bookend the points that you both raised on quality and expectations. I think, the devil is always in the details. So if we have the right data and transparency of data that we're collecting, then we can really benchmark where our gaps are and where we can make progress. For example, in the nursing home scene, the skilled nursing home environment here in Maryland, the data transparency and public reporting is key, and it's a key driver of quality. So, for example, if we're looking at staff continuity and competency, we have to collect that data on turnover, training, and onboarding of our staff. And in nursing home administration, we are penalized for reimbursement measures, or it can be an opportunity to improve, depends how you want to filter that. But, I think it's critically important to look at the retention metrics and what are we doing to train in grief communication and cultural humility to better access and support quality across the providers. And I think that if we can kind of encompass those metrics, then we can get a better base point of where our quality improvement can come from.
This is Carlos Graverin from Bridging Life. I think a lot of really good points have been made. My one concern, though, is regarding how the data will be collected. If we're relying exclusively on self-reported data, I have some concerns about comparing one organization to another, because that obviously there'll be an incentive to report really good data. If it's going to be, compared to other people in the same market. So I would suggest that we sort of try to avoid as much as possible looking at things that are self-reported and being more objective in terms of the data that we're looking at to assess quality.
Agreed.
And this is Monica Escalante. One other factor regarding the CAP scores and the HIS data is that some of the visits that are done at the end of life, potentially by LPNs, for instance, they don't count towards the visit happening. So and a lot of us have on-call staff that are LPNs, so it's not a good reflection of the visits in the last days of life, because it's excluding some of the disciplines we use on a regular basis. So just to put that in perspective, and also I think, Cord, and I see your hand up, you had a list of other quality indicators that you were suggesting to CMS. Maybe it's worth mentioning those.
So I have a National Hospice Locator webpage that lists every known hospice location in the country. And I went out on a limb a couple of years ago and created a quality metrics and ranked every hospice in the country. And that's the default sort results on this public free webpage. And so I don't use stars as one of the 7 metrics that I do include. I don't include stars because so few hospices have them. The ones that I do include that I think we've been talking about this afternoon include hospice visits in the last days of life, which was a really highly weighted measure that I'm going to not weight as much in my next update, really because of what Monica just said. Which is, it's the last 3 days of life, and do you have 2 visits by an RN or a social worker in 2 of those 3 days? And it's difficult to judge, to assess the entire hospice stay based on the last 3 days of life. That said, I do kind of parallel, some feedback that I had from the Medicare hospice team, which is the number one most important thing is that hospices show up. This is like buying a house, right? We only do that a couple of times in our lives. We only die once. We're only around taking care of people, a few times in most people, typically in their lifetime. Hospice needs to be there. And so that staffing, and we can talk about staffing in a couple of different ways. One is through measures that CMS puts out. The other is just through the claims and how hospices are reporting the different discipline visits and the timing of those visits. Like, we could come up with our own thresholds of what is, Stacy, I think you used the term gold standard of an earlier metric. Like, what's the gold standard of hospice staffing? I'm not sure I know. We could model some things and take a look, but that staffing ratio is important. The CAPS measure, definitely recommend this hospice, is kind of informally considered the most important hospice quality measure as an independent question out of all of the hospice items that are CAPS. So maybe some examination of definitely recommend this hospice. What percentage are replying that? One of the other ones, just to throw one more out there to Carlos' point of having some kind of firm, concrete, measurable metrics. Medicare's been looking at levels of care. Are hospices providing general inpatient and continuous? Are they providing respite care? Or are they providing 100% routine home level of care? It's a concern. Are hospices able to staff and provide those higher acuity levels of care? Maybe it's a yes, no, like we provide any, or maybe again, there's a threshold that says, X percentage of days, knowing that's going to be a very small percentage, but that it's provided at all is kind of a warning flag, if you will, that folks are looking at around the country. I actually suspect on each of those measures, without looking, Maryland hospices are pretty strong. There's probably room to differentiate between providers in those, but you look at some of the other states around the country, and Maryland is in a really healthy, strong, good position to be having a discussion of quality.
Mm-hmm.
Well, I think some of the other things that are kind of missing that really affect quality is, we are talking about these length of stays with patients, and every market certainly is a little bit different. But when you have a market that has short length of stay, your quality can be affected from the time the referral is made. We have gaps in the regulations and expectations from assisted living to SNFs to hospices, home health, and the hospital. And you always have a small percentage of patients that kind of fall in those in-betweens. And so you have assisted living saying, well, I can't take this patient back unless they're hospice appropriate. Then they don't necessarily qualify for, hospice under the new expectations or the continued expectations with the audits that we're getting from Medicare. Or you have hospitals saying, oh, well, hospice will do that, and they're going to meet you at home as soon as we discharge you from the hospital. And there's not a true good understanding, even though we're going in and we're trying to set the expectations from pre-referral or at time of referral. The families hear one thing and they're in such a crisis mode that if you have a short length of stay, it can be your quality aspect from their standpoint can be destroyed from the time that referral was made. And so some of that I think is missing too.
One other, if this is brainstorming and we're just kind of looking for ideas, because this one may not be a popular idea, I just put that out there. In hospice, we tend to think about hospice in terms of the pros. Like, what are we doing well? Well, we have X number of visits in the last days of life. X number of people, highly, definitely recommend this hospice. We don't think about the stick. And one of the things that I'm also looking at including in my next iteration for the National Hospice Locator is a stick, which is kind of like, right now, all of my 7 metrics are additive. You know, the higher the quality, the more points, yay. But I'm going to add in a column and kind of pilot this for a while. Well, what if a hospice gets written up, found guilty by the OIG in an investigation? Maybe that ought to be like minus 20 points. What if a hospice has a survey with an immediate jeopardy finding? Like maybe there ought to be a minus something for that. What if ProPublica does an article and names your hospice? Like maybe there are ProPublica, you know, any media outlet. I mean, we don't know, right? I mean, that's not an on-site survey. I would put the survey findings much higher in terms of a consequence. But, you know, somebody gets written up negatively in the media, maybe that's a little stick. Maybe there's a little penalty for that, but maybe there's some kind of negative consequence to be considered alongside all of these positive things that we're talking about. And I'll let you hospice people. Am I off base here?
We do something similar with nursing homes, so that seems reasonable to me. What do other people think?
What does that
That's
look
my
like in
question.
nursing homes?
Yeah, my question for this panel of experts is, why isn't there? Nursing homes are held to their accountability for quality metrics. So I think that it is a fair ask, and it does raise the bar, and it will kind of level the playing field and maybe take some of those other easy points and put them back into perspective, Court. I think that's a great point. You know, it was a bold question, and it's kind of talking about the elephant in the room. But if our aim is quality and how to inspire and hold quality accountable, then I think that is something that should stick for further exploration.
I've seen on Care Compare for home health and Care Compare for skilled nursing facilities a yellow warning sign that means something, and a red stop hand that means something. What do those penalties, for lack of a better word, what does that look like in nursing homes in Maryland now? Like, how's that actually implemented, and how might that cross over for a hospice?
The yellow is, I believe, abuse rating.
Yes.
If there's been an abuse survey within the last year where something was substantiated as part of the survey, and then the red is generally where we don't have any data at all, usually with a red one. What does the red mean?
Special focus.
Special focus facility. Okay, special focus facilities. Yeah.
The special focus is can be something like a harm, a widespread harm. It'll prevent nursing homes from having admissions, or even receiving. They'll be in like a denial of payment if they've gone beyond the standard. Help me out here. I'm lost for the words on this. But if we are in trouble as a nursing home and we are providing subpar care and put other residents at risk or at risk of harm, then we can have those restraints put on us. It also equates to an opportunity for nursing homes to make improvement. I've often gone into troubled facilities that are in an IJ special focus survey, and it does give opportunity to educate staff, to work with your surveyors, and to bring the building back into an acceptable level of compliance. The special focus is serious business for a nursing home. It can make or break. It can make or break that facility on a dime.
And I figure those yellow and red symbols are coming to hospice soon, like this decade, from a CMS perspective. Like, why wouldn't they be? I mean, I sort of see consistency long term across different provider types. So I think I would much rather be in this position with Maryland in helping define and work out what appropriate definitions and thresholds are for those kinds of sticks, those kinds of penalties, then, well, let's just wait 5 years and see what CMS puts on us. I'd rather design it and have CMS look at Maryland and think, well, maybe we can do what they're doing in Maryland across the country. Like, well, that makes sense. They had good input. Again, I know that's probably controversial because we don't talk about penalties so much in hospice.
You know, I'm sorry, I know I'm taking the floor a lot here. It really depends how you spin it, Cord. I think it's an opportunity. I never see, you know, a compliance issue in a building as a negative. It's an opportunity to improve quality. And that's how I train and teach my staff. That's how I run the troubled facilities and turn around an IJ and a special focus. It's, you know, we can be thankful that we will cause less harm because it's been observed, because we're being held to a higher accountability. It's not easy to come out of a special focus. If you don't have that attitude, you won't come out of it on the other side. So it is absolutely an opportunity for quality improvement. And I think that that's really is where it starts.
I like the glass half full, Brandon. That's a good thing.
Somebody had their hand up.
Yes, it was me, Oksana.
Okay.
So the CMS was working on implementing the special focus for hospices, and it was suspended earlier this year. But there's still guidance from CMS, and it's in the state operations manual. I believe it's chapter 10. And, you know, I can send it out to the group, the link to it in a moment. But they do have guidance on implementing civil money penalties. So it's, you know, we as a state agency at OHCQ, if we are your surveying agency, and if we see a pattern of repeat deficiencies, or if there is an IJ, we can recommend to CMS, but then CMS, again, always has the final authority to decide whether a civil money penalty will be enforced or not. And again, this is all relatively new. We luckily did not even have an opportunity to have something observed on the survey where we would bring it to CMS attention and recommend a CMP to be imposed. But the mechanism of enforcement is already in place. It's there. So just wanted to let you guys know that it's there, it's available. And I don't know if they will ever decide to bring the special focus back, because it's not just the nursing homes that they have these programs tracking the poor performers. We have it across other provider types. So it's out there in some shape or form. And we'll see what they do with the special focus program for hospices going forward.
And you're right. You know, I mean, just speaking among friends and colleagues here, you know, associations have been talking for years, well, at least the last couple of years, about, you know, we need to get the bad apples out of the barrel. You know, we need to identify them and get them out. And then when CMS released the special focus program last December, which was kind of an attempt of, it started as identifying the lowest performing 10% of hospices, which would have been 600 nationally, right? About 6,000 hospices, lowest 10%, 600. So they revised that and said, well, we'll release the lowest 100. And then they revised that and said the lowest 50 performing. And once they released the lowest 50 performing, they changed it to a different list of 50. About 44 of them were the same, but they took 6 out, put 6 different ones in, or 8, whatever. And then within a month, those same organizations saying we needed to identify the bad apples and get them out of the barrel sued CMS for a bad methodology for the special focus program. So that being said, the SFP has gone away for now, and we probably need to avoid a lawsuit and figure out what the complications were, what the problems were with the way CMS did that in round 1, and learn from that an opportunity perhaps.
So what do you guys think about adding language that's flexible, but doesn't specify the exact measures to use in the state health plan?
Can you ask that one more time, please?
What do you think about using language that's broad and flexible so that we're not using specific measures? We're not listing specific measures, so that we can be flexible about what measures we use each time we have a CON cycle.
Stacy, this is Steve Farrell. I think that's a positive step. Then you're not in the business of revising regulations, which is a much more cumbersome process. So I would think that makes sense.
Okay. And it allows us to change with Maryland. It allows us to change with the quality measures. It allows us to change with the industry needs.
Mm-hmm.
What are people's thoughts?
I think that helps definitely as you're evaluating the continuity of care across the industry, you know, from a nursing home to the home environment, ALF environment. It certainly gives you a little bit more of a platform as part of operational quality, not, you know, not specific to every different arm of care. We can keep it consistent. It's a lot easier to measure that continuity as well if you're keeping it all the same.
I see it as a both and, kind of like what Steve was saying, keep it flexible in the regulations. So you don't have to change that every time or change the state health plan every time. However, then you need to dig down and be specific and transparent and have timely notification that, you know, we're going to look at this measure. So hospices and providers have a time frame to, you know, look at those measures and you know, kind of see where they're going to be ranking. And so I like the flexibility in the reg alongside, you know, pairing that with some specificity to help providers know exactly what's going to be looked at.
Okay, Delegate Kerr, do you have your hand up?
I do, thanks. I'm just wondering if these measures are self-selected, who approves the methods that were selected, and is there some way that would there be a narrative to justify, provide a rationale as to why those measures were selected and not others?
Yes, actually. Can you go over the process? Jean Marie will go over the process and how we do it.
Sure. Thanks for the question. So we just had this recently come up with the home health review, and what the process is that we take a look at what we would like the measures to be. And the first thing that happens is we post a notice to the public to see if there are any comments that the public would have on the measures that we selected. And then if there are any sort of substantive comments, we would take those to the commission when we go to the next step. And then the next step is, like I said, we go to the commission. So to a commission meeting, we lay out our ideas of these are the measures that we would like to use, and these are the reasons why. And then we let the commissioners, you know, have a vote on it. And that's what we just did in the recent home health review. And it was very collaborative. I think last time they had some questions. We went back and got some more information, had to come back to a second meeting. So it was a collaborative process, and it worked well, I think, for the last home health one. We just did this last month. So for example, let me give an example. So we were deciding whether we were going to use national metrics versus state metrics. We had an opportunity to use above average metrics. So we had different choices of things that we could have included.
I guess just one follow-up question. If one of the reasons for doing this is to avoid having to revisit regulations constantly, do the regulations need to be changed in order to adopt this method? And would that require legislation?
No, the regulations, if we put that into the hospice chapter, would not need to be redone every time we need to do a hospice review. It would avoid that.
Okay, thanks.
Mhm.
Leah Chambers, do you have your hand up?
Yeah, good question. So I agree with everyone says. I'm okay with, and I agree with the standard language, but I think the only question that I have is if we're saying quality, right? And I do understand the steps that you just mentioned on how we would choose measures, but I'm just trying to understand what is the quality, like the data portion of it. Like, are we saying that we reviewed these measures and it appears that these measures due to, like what is that going to be looking at? Like, this is the best measures based off of what? So I'm just trying to figure out what is the best quality portion. Are we looking at low performers? Are we looking at people that perform well? So I just wanted to get a little bit more understanding.
Well, typically we would try to find the highest performers and open up a CON review to the highest performers.
Okay.
But they would have to qualify based on quality plus a number of other criteria, not just quality. There would be other things such as what.
Oh, for CON review, for CON review. Yeah, for CON review, there's multiple things other than quality. There's impact, there's need, there's financial feasibility, viability of a program. So the quality is just one piece of it. I would probably argue one of the most important pieces, but it is just one piece of a CON review.
Okay, thanks.
Amanda?
Hi, good afternoon, everyone. So if the quality measures are going to be selected, then when will the facilities know what the quality measures are so that they can determine their own internal monitoring to determine when they could potentially participate in a CON discussion?
60 days.
Mm-hmm.
So after we select and have everything, once we have everything together, we publish on our website, and then they have about 30 days to review the criteria or to apply.
Right. So they have 30, we post it in the Maryland Register, and the agencies would have 30 days, not just agencies, but members of the community as well, to raise any questions that they have or concerns about using those metrics in a review. But to your point, I think what you're asking is, would they know ahead of time so they could be working on those things? Like, we wouldn't know like ahead of time, ahead of doing a review, which ones we were going to use, but we would use, quality measures that were, as standard as they could be for the moment. It's like the reason for doing this is that these quality measures are always changing. And so this gives us an opportunity. So let's say that we have the HOPE measures in 2027, and we can say, okay, we have this metric now. We want to use this. This is what the threshold is for this review. We want to look at agencies that meet this threshold. So it's give us an opportunity in that way. And I would assume that a provider would be focusing on the same things that we would be focusing on here at the commission.
Yes, and we have no intention of pulling something out of the air that nobody's ever heard of.
Right.
Thank you.
And if there are certain ones that we should absolutely always be considering, that's something to definitely bring up now.
I think one that comes to my mind from the CAP score is if you recommend this hospice. Because that kind of summarizes.
Do you recommend this hospice? Okay.
I think so. That would be one.
Okay. Thank you. And that's a good one that goes across all facility types too. So it's standardized. I like that one. Anything else?
Let me ask a question, maybe of the hospice providers in particular, but really anybody. And where this is coming from is I'm also working with New York, the Department of Health and the state hospice organization there, and CONs, a different process, but one of the things we're talking about in New York is not just hospices stepping up, if you will. New York has the lowest hospice utilization rate in the country, and they're trying to increase that. But they're using that both as a carrot and a stick. Like, we really want to get, the state average up closer to the national average. But part of the problem there, as I understand it, is referral rates from other providers, whether that's hospitals or nursing facilities. That there are things impacting New York's low hospice utilization rate that go beyond what hospices can control. And where I'm kind of going with this, and maybe it's going nowhere, which is okay. Are there things outside of hospice that could be part of this discussion around hospice quality and hospice use that has to do with, nursing homes working with hospices, or hospitals, only half making this up, contributing to a short length of stay in hospices, so that those post-acute care patients coming into hospice, those patients discharged from a hospital within 2 weeks, admitted to hospice, and 2 days later die in hospice. Like, is there a conversation here that might have something to do with the other collegial providers' impact on concerns for Maryland hospice providers?
Or I think that's a good point, and that's what I was kind of getting to, and I think you said it way better with my comment earlier with the referral and how that can affect quality, because we do see that in markets where, a patient gets sent to the hospital, the patient's been in the hospital for 6+ days. Now we have a referral that's immediate, that we're dropping everything to get to that patient because that's what's right to do. And the patient dies sometime before we can get them admitted that day. The patient dies within 24 hours, 48 hours. And so it does affect the quality, or somebody had them on palliative care in a skilled nursing home. They're still being skilled. And now all of a sudden it's an emergency to get them on the hospice within a day or two. That really does impact our ability to care for patients the way that hospice was created initially, for us to care for patients in the community.
I absolutely wholeheartedly agree, Sarah. There's a lot of barriers for nursing homes to accept hospice patients. I will fall back to education every time, and as an administrator who has a heart for hospice providers in my nursing home, it is a language that is just not spoken often enough on the floor, at bedside, in the social services department. There's a lot of regulatory confusion and compliance risk issues that administrators face when we're coordinating and overlapping responsibilities for pain management or documentation, care planning. There definitely could be, I would love to just put a bubble around those hospice beds, hospice patients and their care in a nursing home. But as an administrator, you feel often that your hands are tied from that regulatory compliance perspective. And then it's also educating your staff. And for those of you that have had your hospice providers come into my nursing homes, I invite the educational luncheons all the time, because to be quite frank, and to go right back to what you were saying, Cord, they don't know nursing homes in general, and I come from New York as well, New York, Maryland, and even our bordering states. There is a huge barrier to nursing homes and even the governing bodies accepting the payer rates for hospice and those regulatory risks that we face. I wish that I could just bubble wrap those that need hospice care and just provide the care that we all know that they're entitled to, and that quality care. Often it's the red tape, and it always falls back to education before the patient needs a hospice care. It's working with those partnerships with your case managers at the hospitals and having an administrator that's willing to take the risk. But in order to take the risk, you have to be knowledgeable, and that's just a huge, huge barrier.
And I want to add to that those patients that are under our care for just a few hours or a few days, they are financially very expensive for the hospices. And there are some hospices that choose not to take them at the last minute because they affect their quality scores. And so there's a myriad of issues with those patients that, if you think of it from the caregiver or the patient point of view, everything is in a rush. Everything that could have taken at least a couple of weeks is being rushed to do for them. And sometimes there's not enough time. It's almost cruel being talking about robbing patients of time with their families. So anything that we can do with our quality measures to incentivize other partners that we have to collaborate with us. I think we have one of our members of the Hospice and Palliative Care Network of Maryland working on a white paper about length of stay, because the hospices are experiencing drastically shorter lengths of stays. Right after COVID, it's almost, we thought we would recover after that, but it has stayed. And there's a lot of data. And Amanda, I'm sorry, I'm picking on the hospitals on this, but discharges that could have been done sooner take longer, and the consequences that has quality-wise for the hospices. So how can we collaborate with that? And as a former CFO, I'm always mindful of how expensive that is for the hospices. When half of your patients are dying so quickly, you have to deploy all your resources on an emergency when it doesn't have to be that way.
All right, thank you, everyone. I have one additional question. We started talking a little bit about this, but what are your thoughts on a metric that it gets at disparities? Are there any particular metrics that get at disparities that we should definitely be thinking about?
Stacy, do you have anything like that in other providers in Maryland? Do nursing homes or home health or anybody else have a disparities metric?
I can't think of anything.
I can't think of anything either off the top of my head.
Stacy, I don't think home health has any disparity metrics.
Yeah, I don't think it does either.
Is that not captured in any screening or denial of admission? Or we're not capturing why there might be a denial? Maybe we can kind of keep that in the continuity of language and tuck that in there. Do you know what I'm saying? So if we're already capturing the data on why we are denying a patient or a patient doesn't qualify, we could capture that. The disparities under there. Usually, could be, for all the reasons of disparity, especially in the lower east, Eastern Maryland, we see a lot of that. So I think that we could kind of tuck that, add to the data collection for why we are denying patients, or why, even on the nursing home arm, that is something we could capture, because we're already doing it. If we deny a patient, we have to have a pretty substantial level of documentation on why we would deny a patient.
My concern, this is Carlos again. My concern with regard to disparities, it's on the other end. It's not so much that we're denying care. I'm concerned about areas that have a lot of minority communities that we all know are more difficult to care for under hospice because they're less trusting. And I would hate to give the false impression that for whatever reason, a hospice is turning away patients who are minorities. When in fact they're working very hard at getting those patients to accept hospice care and running into roadblocks that prevent the care to begin with, just because the patients and families are not accepting. So I would caution us to adopt any standard in that way.
Stacy, this is Teresa.
Yes.
A few years ago, when approving a hospice provider, I think it was in PG County, the commissioners really pressed the idea of outreach to minority populations where hospice use was low for the reasons, some of the reasons mentioned earlier. So there may be a way at some point to look at outreach to kind of to get at these populations that are not using hospice services.
Okay.
Yeah, there's certainly a balance between, as Carlos was saying, the receptivity of hospice by, in this case, if we're talking disparities in terms of racial markers, the level of outreach that was being mentioned is really, really important. That receptivity is difficult to measure. I think racial is certainly one form of disparity, but again, if we're in the brainstorming, like putting things on the list just to explore, there's communication and language, Spanish speaking only or other dialects that are difficult, that hospices may not have people fluent in those different languages. Economic, poverty levels, social determinants of health. There are several different ways of thinking about disparities that could be looked at in terms of how hospices, or again, if this is something that's not happening with other provider types, maybe it could be or should be, is to what degree do you have Spanish interpreters? To what degree do you have the ability to serve these other population groups? That it's kind of figuring out. I mean, you have such a diverse community in Maryland that you can't just say Black, Hispanic, okay, we're done. You've got 20 others that I don't even know what they are.
And maybe there are ways to incentivize hospices to do more, not to penalize in any way, but just to create other opportunities to move hospices in that direction. Because there are cultural, as kind of alluded to earlier, cultural issues that may prevent certain groups from wanting to participate, or trust issues, or those kinds of things. And maybe it's, as we're brainstorming, the commission can still support some of that overall, because we did actually do some public relations, promotional activities to push that activity.
Well, and I think another thing to consider too is dialects. When we all use interpreters because it's something that we need and it's required. But I've actually gotten feedback from multiple different groups of people that speak different languages that have said it makes it really hard using an interpreter because essentially, if you're speaking Spanish, there's so many different dialects and different words that are used, and that does make it hard for them to communicate. So they find that it's hard for them to be able to connect with their caregivers. So that's another aspect that we need to think about as well.
And at least for me, I tend to think of, oh, disparities, Baltimore. But perhaps a big, I'm in Colorado, right? Sorry, like I'm the out-of-stater. So I think there's probably a larger group than Baltimore in terms of disparities, and just to kind of put it on the list, rural.
Yep.
Like Western Maryland and the challenges of providing care in rural areas is so different than in urban areas. And it just may be something to be considered as well.
When I think of Maryland, it's really important. We do have a large group of people that have moved to our area that, even in, Hagerstown, we're seeing a lot more diversity happening. So we're spending a lot of time educating our staff and trying to put a more diverse program together. But we're also seeing, especially, not that I want to get super political, but with everything that's been happening the last 6+ months, we're seeing groups of people say, I don't want healthcare. I don't even want to go to the hospital because they're afraid of what's going to happen. I've had conversations with undocumented individuals after hours that they left the hospital planning to go on hospice, and then said when we got there, I don't want to, because we're going through all the questions, do you have, what's your social security number, all the things that you have to have for your EMR systems. And I literally had to say, if you don't have one, it's okay. We just want to take care of you. You have pancreatic cancer, let us help you. And we had to get them to a very comfortable spot. But that's something that's also very hard right now, as people are coming into Maryland or with things that are happening, we've got to take that into consideration as well.
And this is Becky again. I love this conversation, and I think it's so important for us to be thinking about that. But I also think about the patients that do come on to service, and I don't actually think this is an issue in Maryland, but it is in a lot of other states. And that is the live discharge rate. And so I think when we're looking at who are we discharging off of service, but they're still alive, is something that when we get back to, I appreciate what Carlos said earlier about we want some objective data. That's something we all have to report. It's easy to get that information. And I think it tells a certain part of a story too, because a lot of times in other parts of the country, they're seeing that's where some of the disparity is happening. Oh, this patient's too much care. This patient's too much of whatever. You can fill in a lot of the blanks, but they just discharge them off of service then. So, or keep them for a period of time until the reimbursement changes at 61 days, right? And then they go off of service. So I think there's some key points like that we could look at if we're throwing things on the list.
And I want to add one more, is the utilization of Medicaid, right? The percentage of Medicaid patients that we are seeing. And probably consider charity care as well. And again, that's
the hard part with charity care is there's not a common definition. We'd have to kind of define it somehow, which might not be a bad thing.
Yeah.
Well, thank you, everyone. Are there any other comments? I feel like this has been a great conversation. Do you have anything else?
I don't know. Thank you, everyone. Thank you for the conversation today.
Yeah, this has been great. Does anybody have anything last minute before we sign off, or I want to hear anything you have to say?
I feel a lot of gratitude for this collaborative model. Thank you so much. We really appreciate this new take that you're having and reviewing the healthcare plan. Thank you so much for that.
Oh, thanks for the great conversation.
And thank you for the work you do.
Yes, and thank you for the work you do. All right. Thank you. We will get the notes out to you as soon as we can. And the next meeting is in 2 weeks. We will get the notes out to, or not the notes, the presentation out to you by next Monday. Okay? All right. Thank you.
Thank you.
Thank you all. Take care.